Top Bed Talk.
Hello, my name is Glenn Murphy, and what I'd like to talk about in this next talk is methadone use in perioperative medicine. Disclosure information, I have worked as a consultant for Merck & Company, but I will not be discussing off-label use or investigational use of drugs in my presentation. Our learning objectives in today's talk is first to examine the rationale for using methadone in our surgical patient population. Second, review clinical trials that have assessed the effect of intraoperative methadone on postoperative outcomes. And third, discuss some unanswered questions related to the administration of this long-acting opioid in the perioperative period. Well, why should we consider using methadone in our surgical patient population? We know from studies that have been published over the last couple decades that more than 50% of patients suffer moderate to severe pain after surgery, and this can occur even after what we consider relatively minor surgical procedures. We know from studies that inadequate pain treatment can result in increases in morbidity and mortality. More importantly, we've really started to recognize that acute postoperative pain is probably the single biggest predictor for the risk of developing a chronic post-surgical pain. Again, this can occur in anywhere from 30 to 60% of our patients. So it's very important and it's imperative for us as clinicians to really try to reduce acute postoperative pain. Well, since I've been an anesthesiologist, there's been a trend towards using shorter and shorter acting opioids in the perioperative period, going from fentanyl to alfentanil to remifentanil to, again, these shorter and shorter acting agents. What we typically do as anesthesiologists in our practice, and I'm sure it's very similar in your practice, is we use shorter acting drugs like fentanyl in the operating room because they're very titratable. Now, towards the end of the case, we often transition to longer acting drugs like hydromorphone or morphine so the patient can basically have a more prolonged period of pain relief after surgery. Now, when our patients get to the PACU, our PACU nurses typically use, again, in our institution, typically hydromorphone or morphine to get the patients comfortable. And the same drugs are used on the surgical wards in the ICU to treat pain. Well, the problem with this approach is what we typically do is the patients get comfortable on these medications. Then they start having pain and they either press a button to deliver PCA opioids or ask the nurse to get some opioids. The patient gets comfortable again, then starts getting uncomfortable again. We give them more opioids. We have this up and down situation with pain relief in the postoperative period. And I think that sort of up and down thing that patients experience, comfortable pain, is why so many of these patients describe having moderate to severe pain after surgery. Well, the really primary advantage of methadone is a very long-acting agent. It has an elimination half-life of 24 to 36 hours. And again, when we use larger doses, the duration of effect of methadone tends to parallel this elimination half-life. So we get a prolonged period of pain relief. So we don't have this up and down type of pain relief, but we have a prolonged period of pain relief after surgery. Now, this is a excellent review article by Evan Karish, which was published in Anesthesia and Analgesia in 2011. And this diagram really tells us, it really helps us with dosing this medication. Now, we see in the red the area of respiratory depression, and the green area is the analgesia zone where we want to be. And that's reflecting blood methadone concentrations. Now, when we use doses of approximately 20 milligrams, we can see that we get a duration of analgesia of 24 to 36 hours, yet we're below this area of respiratory depression. So we can produce this prolonged analgesia and hopefully be below this area of respiratory depression when we use even these larger doses of the drug. What are some other advantages of methadone? Well, methadone has been demonstrated to have NMDA blocking properties, very similar to ketamine. This may play an important role in reducing hyperalgesia, the development of chronic pain, and tolerance. The use of methadone has been shown to reduce the uptake of serotonin and norepinephrine in the brain, which may play a role in the mood-elevating effect of this drug. Now, it has a rapid onset of effect. We think a long-acting agent may have a slow onset of effect, sort of like what we see with morphine, but actually the onset of effect is typically within 2 to 4 minutes, so it acts almost as fast as fentanyl does. Now, traditionally, it's been a relatively low-cost drug. It's a synthetic drug. However, the cost has recently gone up because there's been increasing use of IV methadone in the perioperative period. This may provide a very simplified dosing regimen in the operating room. Basically, we give a dose of this medication at the start of the procedure, and we don't have to give any other opioids throughout the rest of the case. So it simplifies the intraoperative management of opioids. And it can also simplify the postoperative management of opioids. We may not have to put the patient on a PCA, or the nurse may not have to come every 2 to 3 hours to dose the patient with pain medication. Now, I'd like to shift to some of the clinical studies. Now, methadone has been one of the most extensively studied drugs in medicine, with over 15,000 citations in PubMed. But interesting, there have only been a limited number of studies looking at the use of this drug in the perioperative period, approximately 30 of these studies over the past 4 decades. And I'd like to just highlight some of these investigations. I'd like to start with studies in general surgical patients. Now, the very first study to look at methadone for surgical patients was published by Gorley and colleagues from Australia in Anesthesiology in 1982. Now, in this small study, 23 relatively healthy patients who were undergoing major general or orthopedic surgical procedures were given 20 milligrams of methadone over 1 minute of induction of anesthesia. The results were very promising. What they found was that 9 of these 23 patients required no other postoperative analgesics. This was despite undergoing relatively large and painful operations. 6 of the 23 patients only required oral analgesics, and that was an average 26 hours later. And 8 of the 23 patients did require IV narcotics, but the median duration of analgesia was 20 hours. So these patients received basically a very prolonged period of analgesia after getting this. Now, the same group performed 2 additional studies showing the efficacy and safety of methadone in the perioperative period. But what was interesting, it was another 10 years before any other new studies were performed. Now, this is a recently published study that comes from Evan Karish's group, and this was a study looking at the use of methadone in ambulatory surgical patients. In this study, 60 ambulatory surgical patients were randomized to receive either 0.1 milligrams per kilogram of methadone, ideal body weight, 0.15 milligrams per kilogram of methadone, ideal body weight, or conventional opioids. And what they did is they looked at postoperative pain scores and analgesic requirements while the patients were in the hospital. I think more importantly, what they did is they followed these patients for 30 days after surgery. They gave them diaries to take home where they recorded pain scores, use of opioids, and side effects. Now, what the investigators found was that in-hospital opioid consumption was significantly less in the group that received methadone compared to conventional opioids. But I think the more interesting finding in this study is when they followed these patients for 30 days. In the first 30 days after surgery, patients who received methadone 0.15 milligrams per kilogram had significantly reduced need for oral opioid medications postoperatively. They required half as many pain pills as the group the control group. This group also had reduced pain scores at rest. So not only was it benefit in the hospital during the hospitalization, this benefit lasted for 30 days after surgery. So it may produce this prolonged effect, whether it's from reducing acute postoperative pain, the NMDA blocking properties of the drug, we don't know. But there clearly seems to be this beneficial effect that persists longer. Now, methadone has been most studied in orthopedic surgical patients. Again, people undergoing major orthopedic surgery oftentimes are undergoing major operations. They may be on preoperative opioids and have tolerance and hyperalgesia. So it's a group of patients that oftentimes pain is very difficult to control. This was a study that was published in Anesthesia and Analgesia in 2011. In this small study, 30 patients undergoing complex spine surgery were randomized to receive either methadone, 0.2 milligrams per kilogram at the start of surgery, or a sufentanil bolus infusion throughout the case. And what they looked at were pain scores and analgesic requirements over the postoperative period. What they found was that VAS pain scores were significantly lower 48 hours after surgery in the group that was randomized to receive methadone. Now, it was less at 24 and 72 hours, but this didn't reach statistical significance, likely because the study was so small. However, the investigators also found that the need for postoperative analgesics was 50% less 48 and 72 hours after surgery in the methadone group compared to the conventional opioid group. So again, showing a prolonged analgesic effect that related to the use of this drug. Our group did a larger study looking at this. In this study, we looked at 120 patients who were undergoing complex spine surgery, and they were randomized to receive either 0.2 milligrams per kilogram of methadone at the start of surgery or 2 milligrams of hydromorphone at the end of surgery. These doses reflect what are oftentimes used in our clinical practice. Now, our primary endpoint in this study was PCA hydromorphone consumption. We also looked at pain scores after surgery and overall satisfaction with pain management, and we very carefully followed these people for potential opioid-related complications. What we found was the group that was given methadone intraoperatively required about 60% less postoperative PCA hydromorphone compared to the group that was given hydromorphone in the operating room. We also found that the need for oral pain medications for the first 72 hours after surgery was less in the group that was randomized to receive methadone. So again, significantly less requirement for analgesic agents. We also found that pain scores were reduced by 30 to 50% on the first 3 postoperative days in the methadone group. In addition, overall satisfaction with pain management assessed on a 0 to 100 scale, 0 being completely unsatisfied, 100 being completely satisfied, were significantly higher in the methadone group compared to the hydromorphone group. So patients felt better after surgery if we use this drug. We also looked at the opioid-related complications such as nausea, vomiting, itching, hypoventilation, hypoxemic events, respiratory rate, sedation scores. We found they did not differ between the two groups. Despite getting this long-acting agent, there was not an increased risk of opioid-related complications. What about studies in cardiac patients? There have been several studies in this patient population. We performed the largest study. In this study, 156 patients undergoing cardiac surgery were randomized to receive either methadone, 0.3 milligrams per kilogram, or fentanyl 12 mics per kilo. Now, we use a little bit larger dose of fentanyl to account for potential hemodilution effect of bypass, and again, these patients were staying intubated 4 to 8 hours afterwards. And the fentanyl dose reflected what we standardly use in our practice. Our primary endpoint were analgesic requirements, which were IV morphine, which was nurse administered over the first 72 hours. Then we looked at pain scores at rest and with coughing. And again, we looked at overall satisfaction with pain management. And again, carefully followed these people for opioid-related complications. So we very carefully looked at these people in the postoperative period. What we found was the need for IV morphine for postoperative pain management was significantly less in the methadone group, about 40% less in the methadone group compared to the fentanyl group. But more importantly, we found that the levels of pain at rest and with coughing were significantly less in this patient population. Again, we oftentimes think that patients who are undergoing cardiac surgery don't have significant pain, but they actually do if you look at clinical studies. Most of these patients report moderate to severe pain after surgery, and we could reduce this by using methadone. Again, like the previous study, we found that overall satisfaction with pain management was significantly better in the methadone group. Now, we actually followed the patients undergoing spine surgery and cardiac surgery for a year after surgery to see if there was any beneficial effect. What we found in the spine surgical patients is that they had significantly decreased need for opioid medications and had significantly improved pain scores for up to 6 months after surgery if they got a single dose of methadone at the start of the operation. We found a similar benefit in the cardiac patients, but it only persisted for the first 3 months after surgery. So it wasn't quite a big a benefit. But again, showing that the use of a single dose of this drug at the start of the operation can provide these benefits that persist long after the patient has been discharged from the hospital. There have been a number of studies that have been performed in OBGYN patients also. This was a trial, a small study, but it was a randomized, double-blinded trial in patients undergoing hysterectomy. 30 patients were given either 0.25 milligrams per kilogram of methadone at the start of the operation or 0.25 milligrams per kilogram of morphine at the start of the operation. And they were using the same medication was used in the PACU to get pain under control. Now, the total dose of methadone and morphine used in the two groups did not differ. However, 10 of the 15 patients in the methadone group required no postoperative analgesics during the entire hospitalization, while all the patients in the morphine group required at least 2 doses of postoperative opioids. In addition, VA's pain scores for the first 48 hours were significantly lower in the methadone group. Again, this is a consistent thing we see in many of these studies, lower pain scores and lower analgesic requirements. Interestingly, the same year, a very similar study was published. In this study, 40 patients were randomized to receive either 20 milligrams of methadone at induction of anesthesia or 20 milligrams of morphine at induction of anesthesia. The same medications were used in the PACU and in the surgical wards afterwards. What they found in the methadone group that the average duration of analgesia was 34 hours compared to only 2.5 hours in the morphine group. VA's pain scores were significantly better in the methadone group, and the total dose of opioid required was significantly less in the methadone group. It was 26.5 in the methadone group versus 66.8 in the morphine group. Again, very consistent findings with the previous study. Well, if you look at all the trials that have been published, as I mentioned, most of these studies shown that if a patient is given methadone, surgical patients given methadone, they have significantly lower pain scores and analgesic requirements post-operatively, without an insignificantly increased risk of adverse respiratory events. So it's very, very promising data. However, it's important to understand there are a number of limitations to these clinical trials. The majority of these prospective clinical trials enrolled only a small number of patients. Only 4 of these 30 studies enrolled over 100 patients. Only 11 of the studies examined more than 50 patients. One of the problems, I think, in a number of these studies is that intraoperative and postoperative analgesic management was oftentimes not standardized. And in only two of the studies were patients followed for more than 72 hours. Again, if you're looking for a preventive analgesic effect, it has to be the duration of the drug beyond 5.5 half-lives of that drug. So you need to follow patients for at least 6 days to see if there's a preventive analgesic effect for methadone. And only 2 studies actually did that. What about safety? Well, none of the published studies reported an increased risk of respiratory depression in the methadone group. That's one of the biggest concerns. It's a long-acting opioid, so do you increase your risk of respiratory depression? This hasn't been demonstrated in any of the clinical trials. No adverse cardiac events related to methadone use were reported in any of the clinical studies or any of the perioperative case reports. There's no increase in the incidence of nausea and vomiting reported in the methadone groups. So basically, from what we know from the clinical studies, it appears to be a safe drug. However, it's important again to emphasize that most of these clinical trials were small and likely underpowered to assess safety outcomes. I think before methadone gets more widely accepted to use, there are a number of unanswered questions that need to be addressed by further clinical research. First is, what dose should we use the patients who are undergoing surgical procedures? If you look at the literature, most of the studies either use a dose of 0.2 milligrams per kilogram or a fixed dose of 20 milligrams. Now, there's only been one dose-response study that's been published by Evan Karish, and that was in pediatric spine patients. But we really don't have good dose-response studies to really determine this. It's likely that the dose we use is really dependent on the degree of post-operative pain you expect related to the surgical procedure. So bigger procedures, probably larger doses, smaller procedures, lower doses. But perhaps there's just an equal benefit from these smaller doses, and we really don't know. Another question is, we talked about dosing 0.2 milligrams per kilogram. Is that actual body weight or ideal body weight? What's interesting, only 2 of the studies actually specified whether the dosing was done on actual or ideal body weight. One of the big safety issues is related to does a single dose of methadone prolong the QT interval and increase the risk of arrhythmias? We know from a huge body of literature that patients receiving methadone maintenance therapy for opioid dependence disorder have an increased risk of QT prolongation, torsades de pointes, and cardiac death. However, you look at this literature, it tends to be the patients who are on large doses of this drug over a long period of time. The effect of a single intravenous dose of methadone in the QT interval and risk of arrhythmias is really unknown. We're actually doing a clinical trial to look at this question right now. However, a higher incidence of adverse cardiac events has not been reported in any of the clinical trials, as I noted earlier. And a systematic review of case reports of torsades de pointes did not describe this event after intraoperative methadone use. So again, this is a concern for clinicians, and I think from what we know, it appears to be safe, but again, I think we need further data. Another question is methadone safe in high-risk patient populations? Most of these previous trials looked at relatively healthy patients and excluded high-risk patients such as the elderly and those with cardiovascular disease. One of the questions I get asked most commonly by colleagues is, can we use this in patients who are morbidly obese? Potentially, morbidly obese patients may have a higher sensitivity to the respiratory depressant effects of opioids, but again, this is somewhat controversial. All data we have is this. There's one study that looked at patients undergoing bariatric surgery who were morbidly obese, and they did not show an increased risk of adverse respiratory events in this patient population. Again, it was a smaller study, but again, I think we need more answers to this before we can routinely use methadone in some of these high-risk patient populations. Again, the big concern is if this is a long-acting opioid. Do you have a long-acting, potentially post-operative respiratory depressant effect when you use this compared to conventional shorter-acting opioids? This is a real, I think, the primary concern of clinicians and the primary reason why clinicians are oftentimes reluctant to use this drug. However, the clinical trials haven't supported this belief. But again, it'd be helpful to have a clinical trial that uses very sensitive respiratory monitoring to answer this question. So how do I use methadone in my clinical practice? Well, I typically give a single dose at induction of anesthesia and minimize the use of other opioids. The times we've tended to see respiratory depression is when people have used larger doses of opioids. I'll typically give maybe 100 mics of fentanyl at the beginning of the case and use no other opioids. Now, for procedures associated with higher levels of postoperative pain, such as major spine surgery, open abdominal or thoracic cases, I'll typically give a dose of 20 milligrams at induction of anesthesia. This typically will be effective in providing long-lasting analgesia. It does not appear to increase the risk of respiratory depression. Now, in patients who are older or may have limited physiologic reserve, I'll oftentimes give a smaller dose, 10 to 15 milligrams, due to the potential limitations in physiologic reserve. And then for procedures associated with moderate levels of postoperative pain, such as laparoscopic procedures, a single dose of 10 milligrams at anesthetic induction appears to provide sufficient postoperative analgesia in most patients. Again, this is based on the data that came out of Evan Karish's research in ambulatory surgical patients. So potentially these smaller doses could be of benefit also. So what can I say about methadone in conclusion? Methadone is a unique long-acting opioid that may enhance recovery in patients undergoing surgical procedures associated with moderate to severe postoperative pain. As has been described, methadone could be considered an opioid-sparing opioid. It has a number of unique properties that may be beneficial in these patient populations. The majority of clinical trials have demonstrated that a single dose of methadone given at induction anesthesia can reduce both postoperative pain and need for analgesic agents for up to 72 hours and perhaps longer after surgery. Clinical trials have not demonstrated increased risk of adverse events in patients randomized to receive methadone compared to those given standard opioids. However, further studies are needed to assess what is the optimal dose of methadone to be used for various surgical procedures. And larger scale studies are required to assess the safety profile of methadone use in routine clinical practice. So hopefully this will stimulate some interest in people in the audience in using methadone in their patient population. I'd like to open it up to questions now for anyone who may potentially have questions related to the use of methadone. Thank you so much for your interest.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.